What do you guys think with this one? D? All right. Yeah, so remember, yeah, so D, right? So up high, we think epiglottitis, that's stridor. Anything down low is typically going to be some type of wheezing, right? So that stridor, think high pitch with inspiration, they're going to have that high pitched sound coming up from the up top, and that's typically epiglottitis. See? Y'all agree with that? So we didn't really talk about, what bacteria are associated with what, but we did talk about with lobar pneumonia is typically bacterial. Then we talked about the flu, we talked about mycoplasma, that atypical that has the interstitial pneumonia. And so, based off what this vignette says, right, they have obstructive cough, they have lobar pneumonia, so we know it's bacterial. They don't drink, they haven't been hospitalized. Probably, based off what we know, right? What do y'all think? Okay. You said what? Yeah, strep pneumo. Strep pneumo. So use that, right? Use what's in the actual vignette. Take that. Again, you don't really have to necessarily know, like, okay, this bacteria causes the lobar or interstitial. Or interstitial, you should know that, but we're not getting specific about the type of bacteria that causes certain types of pneumonia. We still know, like, if it's bacterial, it's probably going to be a lobar pneumonia or some other, right? So this one's a little bit different. Okay, I like it. Yeah, so remember, I kind of shared with you what Mr. Weber used to tell another class. There's other classes that Klebsiella cocktails. So Klebsiella is associated with alcoholics. So if you see something like that, somebody's drinking and they throw up and aspirate, you worry about Klebsiella.
C.
I was going to say PPD is negative. Yeah. PPD is negative.
Right? So typically they're going to have that bilateral hilar keratopathy. You're not necessarily going to see granulomas because they're really small. You do have them. They're super small. When they do that biopsy, that's when they actually see these granulomas. Or those granulomas are actually in the lymph nodes, but we can't see that because all we see is that those swollen lymph nodes on the chest X-ray. Walking pneumonia, that's that atypical. That's that mycoplasma, right? The coccidiomycosis, that's the fungal. Typically, that's calcified granulomas. The latent TB, we're going to see that GON complex most likely, or potentially. And the mesothelioma, that's that pleural cancer, right? Sarcoid. This one's pretty easy, I think.
See?
So asthma, right? Now, how do we treat asthma? What are the three things we kind of want to consider when we're treating asthma? Bronchodilators,
Antihistamines.
yeah. Inhaled steroids for the inflammation. And one more, potentially. Mast cells, antihistamines, but then those mast cells, right? They're releasing histamines, they're releasing leukotrienes, so we want to try to combat that too. Typically, in reality, most of the time we just do the bronchodilators and the inhaled steroids. But if you need to add on, then you can add on that medication to kind of calm down those mast cells. So what do we got going on? See, we got COPD, right? But there's two kind of, they're not subtypes, but there's two kind of categories of COPD. We got chronic bronchitis that has that productive cough. They're going to be cyanotic, those blue borders. Why is this not emphysema? Right. Typically, emphysema, can you have production? Yes, but it's not going to be like the chronic bronchitis. So if anything, it's going to be very, very scant kind of mucus that's coming up. They're not typically cyanotic initially, right, because they had that pursed breathing, so they're called pink puffers. They're still COPD patients, but they don't have the same kind of pathology in the lungs. But typically in real life, you're going to see a combination. All right, last one. Yeah, we really only talked about
Or small cell. Sorry.
yeah, small cell. We only talked about small cell really. The other ones were FYs. You'll get those in pulmonology, but small cell is that most aggressive, and that's why we care about it quite a bit. Because if we don't catch it, then most likely it's going to metastasize and kill our patient. Good job, guys.
Yeah, very subset. It's got, yeah, it's got like some craziest thing, kind of some central up. And this little like two shed, little tarp coverage.
All right. So today we're going to be talking about the GI system. We're going to talk. There's two parts of this. So today we'll hit the first part, and tomorrow we'll get to the second part. And then we got liver and then pancreas, and then we're done. But for GI, when we talk about the GI system, there are some kind of key terms that when you see that, you kind of associate that with the GI system. So enteric, intero, that all means just relating to the GI system, the gastrointestinal system. Bowel movements. So a lot of patients are going to come in and they're going to say they have diarrhea, right? Do they really have diarrhea? Maybe, but when we talk about diarrhea, we're talking about how many stools they're having per day. So if somebody has like one watery stool and they come in and they say they have diarrhea, you should know that the patient is saying that because they relate watery stool with diarrhea. And yes, diarrhea is watery, but it's the amount they're having in that day. So if they have 3 or more in that per day, then that classifies it as diarrhea. Constipation, that's the reverse, right? A person's gonna come in, they're gonna say they're having a hard time passing their bowel movements. They may have kind of small, firm stools, but what we're looking at is how many are they having throughout that week. So if they have 3 or less per week, then that classifies as constipation. So patients are gonna use these terms, and you just let them talk, but in your mind, you know that what you're looking for is how often. And that's one of the questions you ask. You ask them how many stools are you having, how often are you having. That's part of your history taking. But just know that there's a time frame when we talk about diarrhea, constipation. Then emesis, that means vomit. So patient's not going to come in and say that they're having emesis, but when you document, you want to use those types of terms. You want to sound like you know what you're talking about. So you use those types of terms whenever you document your medical records. Eruption, that just means burping or belching, and flatus or flatulence, that just means that they're passing gas. So when we talk about the GI tract, right, there's components of it, and they're important, and there's a reason why we have certain cells in their location, because they do certain things for our body. So the GI tract is just a big kind of smooth, or big long open tube, right? We need to eat, and then when we eat, we defecate. We pass that stool. But because it's open to the world, we're ingesting things, we're eating things, we're putting stuff into our body. Sometimes that can cause issues. But when we eat, right, when we're swallowing food, whenever we're drinking fluids, hot fluids, we have certain cells within that first part of our GI tract, from our mouth to our stomach, right? Essentially in our esophagus and our mouth. We have those squamous cells. Those are very tough cells. They can withstand that kind of friction that we're introducing to them whenever we're chewing and swallowing. We want those cells down because they're going to protect our mucosa. Then in our stomach, all the way down to our anus, we have these columnar cells. Our columnar cells they're very important in digestion, because they help break down things. They release certain chemicals, and they help us absorb food as well. So we want those types. Also, they're a lot they're not thicker, but they're a lot, I guess, longer, if you will. They protect us. They protect our stomach from the acid that we make, and they're kind of all the way down as we process that food. Then back to the anus, again, that's squamous cells as well, because things are passing through there, so we want something tough, protected, because if not, if we had very cells that weren't as tough, when we pass those stools, we would have a lot of kind of not tearing, but breakdown and possibly slippage of those cells. So we want those cells there for a reason. Outside the intestines, this is very important, especially when we talk about peritonitis. So we have our visceral peritoneum. That's that kind of protective layer that sits right on top of our organs. The thing with that visceral peritoneum is that, and the actual organs themselves, they don't have a lot of nerve innervation. So whenever they're inflamed, whenever they're swollen, whenever they're damaged, you may feel some discomfort, but they don't have that same kind of, you are not going to have that same pain response as you would as if the parietal peritoneum was affected. That parietal peritoneum, that sits on the outside of our abdominal cavity. And that stuff is very sensitive. It has the same kinds of nerve cells that our skin does. So whenever that thing's inflamed, we're going to know it. We're actually going to be able to kind of pinpoint where that pain is at. I'll talk about more of that here in a second. But that visceral, again, it kind of covers the intestines. And that parietal, it's one kind of big, it's all connected. But that visceral is right on the intestines. That parietal kind of outlines our abdominal wall. GI tract, it has a robust blood system, and we want that there because its job is to help, protect us and absorb all the nutrients that we're trying to ingest or trying to absorb. But the problem with that is that if there's bleeding, if we have damage to that blood or to that system and there's bleeding going on, we can bleed a lot in our abdomen. That can cause issues, especially if there's a perforation. Open-ended, I already talked about that, so that kind of makes us prone to getting certain diseases, because if we get some type of bacteria or virus in there, we're going to know it. Also, too, because what we're eating, sometimes it's carcinogenic, so if we let that stuff sit in there for too long, or we eat a lot of whatever is not good for us, that can potentially lead us down the pathway of cancer. And then because it's a hollow tube, it's prone to obstruction. So if there's something in the way that blocks our movement out of that tube, we can have other issues, and we're going to notice that in our patients, especially if it's some type of cancer. So we break up the GI tract in the upper GI tract and the lower GI tract. The upper from mouth to the duodenum, and then from the lower, from the jejunum all the way down to the inguinal. But notice notice where the lower GI system starts, or the lower GI tract starts. It's at the ligament of Treitz. Is that really important for us to know? Maybe, right? What really, I don't know why they do this. The surgeons, whenever you're doing your surgery rotation, they like to ask you that question. They like to ask you, where is that differentiation between the upper and lower GI tract? So if you know that, they might like you better. I don't know. They ask very strange questions, but it is kind of important, especially to know where the upper and lower starts, because with the upper, if we have some type of bleeding going on, right? If we have bleeding going on within our stomach or that duodenum or esophagus, if we throw up, if we vomit, that's going to be typically bright red. Or if we pass that stool, if we swallow that blood and pass it, it's typically going to be dark, right? Because it's getting oxidized through our stomach, and so when somebody has a bowel movement and they're bleeding, typically that's a very black looking stool. Versus the lower GI tract, if they have bleeding going on, depending on where it is in that tract, it's typically going to be bright red, right? So that kind of helps differentiate where somebody may be bleeding. Is it upper or lower GI tract? All right, so let's talk about abdominal pain. So I kind of alluded to already. So the visceral pain, right? Visceral abdominal pain, it's very poorly localized. When a patient has, distension of their organ, of their GI tract, or that viscera that's actually covering the organ is inflamed, a patient's going to have a hard time telling you where that pain is at. They're going to come in, they're going to say, hey, my stomach hurts, and you're going to say, point with one finger where it hurts, and they're not going to be able to because it's hard to distinguish that. Typically, they're going to kind of like put their hand over their abdomen and say it hurts there. When that happens, that should tell you, okay, either that visceral lining's inflamed or maybe that organ is being distended. Because like I said, that viscera, the organ, has a very, very low, doesn't have a lot of nerves there. So whenever it becomes irritated, it's very hard for the patient to characterize where that pain is at. They may say it's crampy, colicky, especially if there's some type of blockage going on. If that intestine is trying to contract against this blockage, every time it contracts, it's going to feel painful, and the patient's going to kind of be squirming and moving around a lot. But again, it's going to be hard to kind of point where exactly it hurts at. Versus the parietal pain. So if the parietal peritoneum is inflamed, that's when your patient's going to tell you it hurts, right here, or it hurts right here. They're going to be able to actually tell you where that pain is at. Because like I told you, that parietal peritoneum, that has a lot of the same nerves that our skin does. So it's very easy for our brain to say, this is where the problem is at. So that helps us kind of figure out, okay, this is where we need to look at, whether we get whether we do a palpation or imaging. But it fixes us to where we need to find out where this issue is at. The problem with parietal pain is that it's very painful, obviously. And so when you compare that to the visceral pain, our patients are moving around because they're uncomfortable. With parietal pain, that's going to be, your patient's going to not want to move. Every time they move, every time they move that parietal peritoneum, it's going to cause a lot of pain. So they're going to be very, very stiff and still. They may have guarding. Essentially, that's where your patient, you go and you try to palpate their abdomen, and they're stiff. Their abdomen is rock hard because, and they're not doing it on purpose. It's just because they're in so much pain, their body reflectively just contracts the abdominal wall. So when you try to push and try to figure out where that pain is located, it's going to be very hard for you to appreciate that. Rebound tenderness, that's pretty typical with that. Rebound tenderness is where you try to push on the abdomen, right? You push. Maybe it's painful to the patient, but as soon as you let go of that pain or that abdomen, it's going to be a lot worse. It's going to be more painful. Because that parietal peritoneum is inflamed, and when we push on it slowly, we're stretching it out. It's not going to feel good to the patient, but as soon as we let up, that's when that parietal kind of snaps back, and that's going to cause that patient a lot of issues. So that kind of leads you to say, oh, maybe there's something going on with that parietal peritoneum. And then referred pain, with that one, that just means that there's pain in the abdomen, but the patient feels it somewhere else. And what's very classic with this is gallbladder. With gallbladder pathology, we'll talk about gallbladder I think tomorrow. With gallbladder, if that thing is inflamed and angry, patient may have right upper quadrant pain, but they also might feel it in their back near their like right scapula. Because the way those nerves are are coming out of the spine, our brain, because they're very close to those nerves that innervate our shoulder, especially the back of our shoulder, whenever that we get that signal, our brain can't differentiate where is this thing at, because it's all coming to the same region. So that's called refer pain. Typically it's going to be on the same side. It may be in the center, especially if it's like in the center organ like the stomach, but you can sometimes get refer pain, and that can kind of throw you off sometimes. So peritonitis, right? So when we think about peritonitis, we think about the parietal peritoneum being inflamed. Can the visceral peritoneum be inflamed? Yes, it can. But that parietal is going to kind of give us that key of where that pathology is at. There are a few things that can cause it. Infections, obviously, if you have some type of perforation, if you have perforation in your stomach or your intestines, and then we let that stuff seep out into the peritoneum, that's going to cause a lot of inflammation because that thing's becoming infected. That's it's a very, very serious sign if somebody has that occurred. Because typically we need to get them to the OR quickly to figure out what happened, kind of clean out that peritoneum, or remove whatever caused that perforation. We can also have sterile. So when we talk about sterile, this is not infectious. This is typically from something called pancreatitis, and we'll talk about that when we get to the pancreas block. But sometimes our pancreas becomes so inflamed that it starts to release its enzymes, and when that happens, it gets into the peritoneum, and when that happens, it causes this kind of widespread inflammation. You do worry about scarring, so adhesions. So if the intestines are inflamed, what happens when things try to heal? They scar down, right? And if they scar down, they can scar down on the intestines. They can cause issues like blockages and just a lot of discomfort. So we do worry about that with peritonitis. We talk about typically it's going to be a sharp pain once that parietal peritoneum is inflamed. That rebound tenderness. A lot of times we think about rebound tenderness when we're talking about appendicitis. That's not the only thing that can cause it. So somebody has rebound tenderness. Maybe it is appendicitis, but it could be some type of other issue. It could be ovarian torsion. It could be perforation. Anything that's inflaming that peritoneum. We go and try to do that rebound tenderness test. And don't just think appendicitis. It means that something's going on in the abdomen and we need to figure it out. If we don't treat peritonitis, it can lead to sepsis and death because there's a lot of inflammation going on. When there's inflammation, we get what? We get a lot of vasodilation, right? And if there's bacteria involved with that, not only are things seeping out to the peritoneum, but they can actually get into the blood as well. So we do worry about infections like sepsis, bacteria get into our blood. If that happens, we're going to admit them. Typically, start them on antibiotics and then try to remove whatever caused that rupture or that peritonitis. All right, so when we eat, right? When we eat, we're chewing, right? We're drinking fluids, and then we're also swallowing air. So that mixture of food, fluids, and air is called chyme. Whenever our intestines are trying to move what we ate through our GI tract, it makes this kind of, what's called an emulsion, kind of this mixture, right? Whenever our intestines stop moving forward, so when they stop having peristalsis, that just means that the intestines are moving forward. We can cause that emulsion to separate. And when we do that, we get this air fluid level. So this picture over here, these little vials, that kind of shows you on the left-hand side, when things are moving and things are working like it's supposed to, things are mixed together. But when that stops, that air fluid level, that air can separate from that mixture. We can actually see that on an abdominal x-ray. There's two different things that can cause this. So ileus, right? Ileus just means that the intestines are no longer moving. Most of the time, this is going to happen when somebody has some type of abdominal surgery. It's actually very, very common. Whenever you open up the abdominal wall and you go in there and you're doing whatever you need to do to fix whatever issue's going on with the patient, those intestines don't like that. And when that happens, they stop working for a little bit. Most of the time, if you just give them time, don't feed them for a little bit, the intestines will kick back into gear and they'll start moving again. But if they stop and we get that, things aren't moving like they're supposed to, we can get that separation of that chyme, that mixture where we actually see air on an abdomen, on a abdominal x-ray. Versus an obstruction, if we have something blocking the intestines, right? If we have a tumor or if we have some type of stricture or whatever, right? Something's not allowing that peristalsis, that movement of that chyme, then we can also get that air fluid level separation. And these strictures, I want to kind of focus on these strictures here for a second. These strictures are very, 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 very common, especially if somebody's had multiple surgeries on their abdomen. You go in there and you did some type of surgery on the small bowel, large bowel, things try to heal, right? And when they heal, they start to form scar tissue. When that scar tissue, what do scars like to do? They like to contract. They like to contract, and if they contract over that intestine, they can cause that stricture, which can cause that blockage. So if somebody has a lot of surgeries on their abdomen, consider that it could be some type of stricture. With the paralytic ileus, again, the intestines, there's no blockage. They're just stunned for a little bit. Once we give them time, typically it's going to go back to normal. Versus the obstruction, there's something in the way, right? They still work, but there's something in the way preventing that flow, and so we can get that separation. We can get that air in the air level, get the air on the KUB on the abdominal X-ray. All right. So achalasia. Achalasia is one of these weird things. We don't know why it happens, but we do know that for some reason the nerves at the lower esophagus and at the very distal end of the esophagus, they don't work like they're supposed to. So when we're chewing and we swallow our food, that lower esophageal sphincter, that part that opens up into our stomach, it doesn't open up. It doesn't open up, right? Not only that, but the distal end of our esophagus, because those nerves are not also working like they're supposed to, when we swallow, they're not having peristalsis as well. Maybe they are, but it's not coordinated with that LES. So with that lower esophageal sphincter, we're trying to push food, and that sphincter is not opening up, and the distal esophagus is not contracting correctly, we start to get this backup of food essentially, which can sometimes dilate that lower esophagus. Now, with time, especially if you keep eating, and especially if that upper esophagus is still working like it's supposed to, you're going to create a lot of pressure. So with time, you may be able to push some food into that stomach, but that lower esophageal sphincter doesn't work right. It doesn't want to relax and open up like it's supposed to. So we're like pushing this food, we're like forcing this food down to the stomach if we can. But if we can't, or it's very difficult, that lower esophagus is going to start to dilate. When that starts to dilate, we can actually see that on an X-ray, and I'll show you what that looks like here in a second. But the thing with these patients is that they're going to have a hard time with swallowing both solids and liquids. So think about that, liquids, right? Most of the time, if somebody has some type of mass in their esophagus, they can still swallow liquids. They have something kind of blocking the way, but when they're swallowing liquids, they can still swallow that. But this thing is both solid and liquid. So that's how narrow, that's how tight this lower esophageal sphincter is. That's not allowing either or through. They're going to have chest pain because think about that. If you have this kind of big mass in your esophagus and it's dilating, it's going to push out on that esophagus and cause kind of this kind of substernal, kind of upper chest pain. They may have regurgitation. So if you're not getting food into the stomach, if it comes back up, it's going to look like chewed food, as opposed to if it was in the stomach and it had some digestion and then you potentially belched it up or burped it up. It may still look like food, but it's going to look like it's broken down. This is not like that. When you do a barium contrast, when you swallow barium and you shoot an X-ray, you're going to get what's called a bird's beak appearance, and I'll show you what that looks like here, but it's very characteristic of achalasia. Now to treat this, what we're going to do is we're going to typically send them over to GI, and they're going to do a couple things. They're going to try to dilate that lower esophageal sphincter to try to open up that thing that's super tight and narrow, and try to get that open. Typically they'll do a balloon where they'll put this little balloon into the esophagus and pump it up and just try to make that thing get a lot wider. Or they can do Botox injections, which actually helps relax that lower esophageal sphincter. And sometimes they'll do surgery if they fail that. So here's that bird's beak appearance. So it looks like a bird to me. I don't know about you guys, but it looks like an upside down bird. But that's that esophagus, and as it starts to get down to that sphincter, it's not working like it's supposed to. Go ahead.
Is that, so the balloon would be first line, and if that doesn't work, Botox and then surgery?
It depends. It depends. In reality, the GI doc's going to evaluate them and kind of see how severe it is, and pick an option for the patient. But yeah, so definitely if you see some type of bird's beak, pathology in real life, then think about pigmentation. All right, so GERD. Everybody's had GERD, I would imagine, so we can kind of all relate to this. And this is going to be a very common thing patients are going to come and see you for. What's happened here is kind of the opposite. It's the opposite of achalasia. That lower esophageal sphincter is too loose. It's too relaxed. And that sphincter is what controls our stomach acid prevents it from getting up into our esophagus. So when that sphincter is too relaxed, it allows our gastric constricts to actually get into our esophagus and cause a lot of irritation. So it feels like this burning, heartburn, right? A lot of things can lower this. A lot of things can lower that tone of that sphincter. Smoking, it's really the nicotine that can actually cause that thing to relax. Caffeine, tomatoes, chocolate, all the good stuff in life, right? And it's gonna be hard to tell your patients to stop these things that they enjoy doing, because why, right? If there's a medication out there that can treat this, why would I stop all these good things? And you want to try to get them to stop it if you can. And you want to try to let them know about the risk factors when they have chronic GERD. We'll talk about that here in a second. But it's very, very hard to get patients to kind of stop doing whatever it is that's causing their GERD symptoms. Let's see. So most of the time when people have GERD, it can be worse after meals and worse at night. And think about it. If you have a lot of food in your stomach and that thing is distended, that sphincter is going to be a little bit open, right? So it's going to allow, especially as we're trying to break down that food, it's going to allow that acid to go back into our esophagus. Worse at night, I think that makes sense. When somebody's laying down, right, when they're laying down to go to sleep, you don't have gravity anymore kind of pulling those acid secretions back to the stomach. A lot of times patients, when they're laying supine, when they're laying flat, they're going to feel like their GERD is worse, especially if they eat and then lay down. They're going to have recurrent heartburn. So again, since that burning kind of pain that they're going to have in their chest, patients are going to think sometimes they're having a heart attack, but you try to get that history, and if it sounds like GERD, that makes me feel better all the time. Water brash, I think most people have experienced that, where you kind of belch, you kind of burp, and you kind of get this acidic taste in your mouth. That's very common with GERD. They can have a chronic cough. That's probably one of the most common things that somebody comes in real life with they're saying, hey, I've been coughing for 2 or 3 months. You ask them, do they have GERD? And if they do, if you treat them for that cough can improve. That's pretty common. Asthma, I think that makes sense. If we're having our acid kind of coming back into our esophagus and we aspirate it, that can cause inflammation of our airways. And somebody who's prone to asthma, that can cause bronchoconstriction. We try to treat this by lifestyle changes. We try to tell the patient, hey, don't eat X, Y, Z, stop smoking, reduce your caffeine intake. Don't eat before 2 to 3 hours before going to bed. Don't lay down before bed. Actually raise the head of your bed so we can, some people try to do that, unless you have like a really cool bed that goes up and down. Typically we'll just say, hey, sleep with like 2 or 3 pillows under your back. That way you can bring that, use gravity to bring the acid down to your stomach. There are medications out there that we use. I threw these in here, just some of the common things, the common meds that we use. I don't expect you to memorize these. I don't know if you had this yet in pharmacology, but PPIs, proton pump inhibitors, those are what we typically use for GERD. Those are the best ones to actually use. Omeprazole is one of them. You can use H2 receptor blockers. Famotidine is one of them. I don't really like the antacids, the Tums, because they don't work that well. They're good for like treating symptoms now, but they don't treat the symptoms in the long run. So typically we'll do a PPI. If they fail medical therapy, if they fail the medication, then sometimes we can refer them to a surgeon. And there's something called a Nissen fundoplication, where they actually take the fundus of the stomach, the upper part of the stomach, and they'll wrap it around that lower esophageal sphincter to kind of make it more tight. That's kind of like worst case scenario. Hey, I got all these issues, these meds aren't working. Maybe I have some other pathology in my esophagus. Then we'll kind of go to that if we need to. So, just example of GERD, again, I think we all kind of know what that looks like. That acid's coming back into our lower esophagus and causing some of that irritation. And then down below, that's that Nissen fundoplication, where we take that fundus, wrap it around, and kind of just give it some more support. All right, so Barrett's esophagus. We kind of talked about this last block. This is what you worry about when somebody has chronic GERD. When somebody has GERD for a very long time, and they're getting all that acid going back into the esophagus, it's gonna cause damage, it's gonna cause changes. And this is what we wanna avoid, because if a patient develops Barrett's esophagus, that's essentially, pre-cancer, right? If we don't control whatever's causing this, which is typically GERD, then they're gonna develop that cancer, and then once that cancer develops, it's gonna be too late, right? So once somebody has Barrett's esophagus, we're really trying to make sure that we're treating these patients, we're putting them on high-dose PPIs, considering that disinflammation if we need to, because there's such a high risk of this turning into cancer that we want to avoid that. Smoking alcohol, I think you guys know, we talked about that already. When you combine the two, even worse. But you definitely want to try to avoid this, especially with our chronic GERD patients. If somebody has this, it's going to be very, very, it's going to be a high likelihood that they may progress into cancer. So hiatal hernias. So hiatal hernias, these are actually very, very common as well. Essentially what's happening here is that where our esophagus comes through our diaphragm is called the esophageal hiatus, right? There's this opening. Sometimes that hiatus can be weak and open up too much, and when that happens, it can actually allow some of our stomach to go up into our esophageal region. A lot of things can cause this, but probably the most common cause is obesity. So increased abdominal pressure. Think about if somebody is very obese, they have a lot of mass on their abdomen, and they go to lay down, or typically they go lay down. That mass is pushing on their organs, and over time that can cause this esophageal hiatus to be a lot weaker. So if somebody's obese, that's probably the most common reason that this can happen. But there's two types. There's two types of hiatal hernias. We have the sliding type, where a portion of the stomach actually slides up into the esophagus. So that gastroesophageal junction, that's that separation between the esophagus and the stomach. That junction goes up into the esophagus, right? This is very, very common, and a lot of patients are going to have chronic GERD with this. So somebody may come to you and they say, oh, I've had GERD for 10, 20 years, and they've been taking PPIs, proton pump inhibitors. If they haven't been evaluated for this, it may be worth doing that. There's different ways you can do that, but it's very, very common with somebody with chronic GERD. The rolling periesophageal part, or type, it's actually not as common, but this is more dangerous. So what happens here is that upper part of the stomach can actually roll next to the esophagus through that hiatus. When that happens, it can get stuck. When it gets stuck, we call that incarcerated. If it gets stuck for a prolonged period of time, we can actually cut off that blood flow. That's called strangulation. And if we cut off part of that blood flow to that part of the stomach, it's going to start dying, right? So this is not good. Most of the time, when people will either have either types, most of the time the sliding, you're going to have a lot of heartburn. With the rolling type, you're going to have that sharp pain. You're going to have that intense pain. It can regress. It can get out of that. It can get out of that entrapment. But if it keeps happening, then they're going to go in and they're going to do surgery to try to correct that. With the sliding type, the most common type, we don't really go and do surgery unless they're having Barrett's esophagus, or they're having chronic reflux that we can't treat. Most of the time we're going to treat them the same way like we treat GERD, and if it's really, really bad, or especially if they're getting recurrent episodes of that rolling type, then we're going to send them to a surgeon and they're going to kind of tack that down. Here's an example of that sliding. So you can see how it's kind of coming up into the esophagus, right? Very, very common, versus that rolling type is coming to the side of the esophagus through that hiatus. And if that happens, we can actually cut off blood flow and that thing can die. So if it doesn't recede, then we're going to go in and send it to a surgeon. All right, so esophageal bleeding. So there's several things that can cause esophageal bleeding. The most common type is the Mallory-Weiss syndrome, or Mallory-Weiss tears. With this one, somebody vomits, right? Typically we think about alcoholics, but it could be from people who, like bulimics, who make themselves vomit. That forceful vomiting can actually tear that superficial mucosa of the esophagus. And when that happens, they're going to have a little bit of bleeding. So patients are going to come to you and they're going to say, hey, I'm vomiting blood. And you ask them, what does this blood look like? Like, what does the vomit look like? most of the time it's not a lot of blood. We call it streak hematoemesis. So they got some vomit, they got some blood, but it's not just a ton of blood that they're vomiting out. Typically, because it's so superficial, this is going to resolve on its own. It's going to resolve on its own. There's not much we have to do. If they're an alcoholic, obviously we're going to try to get them help. If they're bulimic, we're going to try to get them help, but it's self-limited, so they're not going to bleed out with this. With the Borges syndrome, this is actually a complete rupture of the esophagus. And this is classically followed after somebody overeats. And think about it. When you eat, right, if you overeat, if you eat too much, your stomach is full of food. It's full of food, right? If we overeat and we have to, for some reason, vomit, maybe our stomach's too distended and it's like, yeah, I gotta get this out. It takes a lot of force for our body, our abdomen to contract to get that food out of there because there's so much kind of filling that stomach. On top of that, whenever typically when we vomit, we're breathing. I don't know if I'm sure you've all vomited before. I know I have. When you vomit, you're breathing and you don't feel good, right? If you breathe in when you're about to vomit, right, what are you doing to your intrathoracic pressure? You're decreasing it, right? You're decreasing it. Because when you breathe in, you decrease it. That's how we get air to our lungs. Now our stomach's full of food and we're going to vomit. If that upper esophageal sphincter, so there's a lower, there's an upper, if that upper one doesn't relax and let that food out, we breathe in, and we're trying to have this forceful vomit, and that upper one's shut, and our intrathoracic pressure is low, we like to go from high pressure to low pressure, and if that thing is trapped, it's going to go through our esophagus. So you can cause this perforation all the way through the esophagus, because that pressure in our cavity is lower, it has nowhere to go, so it's going to go from high to low, it's going to perforate that esophagus all the way through. If that happens, that's not good, because what's next to our esophagus? Our lungs, right? Our medial side of it. If we get food in there, if we get bacteria in there, if we get acid in there, it's going to cause a lot of issues. So that's an emergency. If somebody has this occur, they need to go see a surgeon right away. Now, what can happen with this is that, whenever that happens, we have air in our esophagus, right? We're swallowing air all the time whenever we eat. That air can actually start to, it's not the lungs itself, but it's the air coming through our esophagus from what we swallowed that can actually cause a subcutaneous emphysema. So when you touch the chest, when you touch up here in the neck, it's going to feel like Rice Krispies. You're going to feel like popping, right? That's a sign that somebody has some type of perforation of their esophagus. Obviously, they vomited. They're going to have pain because that thing is ruptured. But when they have air under their skin, whenever you push on that, it's going to feel like Rice Krispies, and that's a sign that that person had a complete rupture of their esophagus. And esophageal varices, we're going to talk about this more when we talk about the liver, but in our esophagus, under our mucosa, we have veins, right? If for some reason those veins become distended, so somebody has liver disease, cirrhosis is what we typically think of, that liver is fibrotic, and so blood can't flow through it. So when it can't flow through it like it's supposed to, it starts backing up. And when it backs up, it can start backing up into our esophageal veins. And when they become distended, they can actually rupture. And when they rupture, it's a very, 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 very dangerous, bad sign. Because it's very hard to go into your esophagus and stop the bleed, right? We're not going to do that. And they're going to bleed quite a bit because there's nothing in there stopping that bleed if we don't get them to a center where they can actually treat this. Because of how much bleeding is going on, they're going to have copious hematomesis. They're going to have a lot of blood whenever they vomit. It's not like the streak hematomesis. It's a lot. If it's a large rupture, they're going to bleed out because they're going to go into hypovolemic shock and die. If it's a small rupture, it might stop bleeding on its own potentially, but we're still going to get them over to somewhere where they can actually evaluate that and make sure it actually stops. But typically, when people have esophageal varices, that typically means that they have very, very severe liver disease. And then most of the time, they're going to die pretty soon afterwards because you need that liver to actually make a lot of things and help with the nutrients absorption. Here's an example of that Mallory Weiss. So it's superficial, not going to be bleeding a lot. You're going to have some streak blood in your vomit, but not quite a bit, not a lot. Versus that Borges, again, you have a complete rupture. It's getting into that mediastinal area. very, very bad, very, very dangerous. And then you have the esophageal varices. You see that normal, you don't typically see those veins, but on the left-hand side, those veins are dilated. If they rupture, you're going to start bleeding out and eventually die. All right, gastritis. So the stomach, right? The stomach has a couple of jobs. Its job is to essentially break down the food that we ingest, and it has hydrochloric acid to help break that down, and it has pepsin to break down the proteins. But we also, because of that environment, so it's very hostile, right? We also need protective factors. So the cells in our stomach, they release something, and the blood, we have blood that flows there too. They release something called bicarbonate, and that helps kind of neutralize the acid that our parietal cells, that our acid-producing cells are trying to make. Those epithelial cells of our stomach, they also make mucus. We need that bicarb, we need that mucus to protect the lining of our stomach. If we don't have that acid that we're making, that pepsin that we're making, is going to start damaging those cells. When that happens, you worry about, it's going to be a lot of inflammation, so that's why it's called gastritis. But you worry about perforation, you worry about chronic inflammation, which can lead to gastric cancers. And so it's a very, very, very dynamic area there that we need to protect. There's a lot of things that can cause. So when we talk about gastritis, we think about it as acute and chronic, right? Acute typically just means for a couple of weeks that you have this inflammation in your stomach. A lot of things can cause it. If we don't have good blood flow to our stomach, our cells of our stomach, they need blood, right? They need blood to do what they need to do to make the mucus, to make the bicarb. So if we don't have good perfusion there, they're not going to be able to make those protective factors which can cause inflammation. Anxiety, right? Increased acid production from stress and anxiety. If you are anxious or stressed for a not prolonged period of time, but longer than a day or so, that can actually cause our vagus nerve to cause our cells to make more acid and reduce that production of those bicarbs and the mucus, which cause inflammation. Probably the most common thing we're going to see are those exogenous irritants, those NSAIDs, right? NSAIDs, ibuprofen, naproxen, those things that we commonly prescribe in the military. We talked about it last block. They reduce our prostaglandins, right? That COX pathway. Prostaglandins are actually protective in our stomach. Our stomach cells make prostaglandins, and those prostaglandins are what help us make that mucus and that bicarb. When we decrease that production of the prostaglandins by giving a patient NSAIDs, we're going to decrease those protective factors, which is going to cause our patients to have that acute gastritis. Chronic gastritis is essentially acute that's just prolonged. There's different causes for this one though. Chronic irritants like NSAIDs are definitely one cause, but you also worry about autoimmune disorders and infectious agents, and we'll talk about those here in a sec. The bottom line, if the stomach is chronically inflamed, it's going to bleed, you're going to have ulcers, and then you're at risk for having perforations and cancer. So this picture here, I think it's a good representation of kind of what goes on in the stomach. So let's kind of start here. So blood flow, right? We need blood. That blood is going to deliver those nutrients, the energy that our cells, that our stomach cells need to actually make that mucus and that bicarb. It's also going to give us bicarb too. So that blood flow actually gives us some of that bicarb, which helps neutralize that acid. We got epithelial cells here, which help make bicarb. They also secrete mucus, and we need that mucus layer over our cells there, because if not, that acid that we're making also is going to start to cause irritation and damage to those epithelial cells, which is going to cause those ulcers and potentially perforations. Those prostaglandins are important. Those prostaglandins are what help our epithelial cells make that bicarbonate mucus. So if we don't have that, if we're giving NSAIDs, which are reducing that COX pathway, we're not going to make prostaglandins, and we're not going to make biocarb, we're not going to make mucus, and that's going to cause irritation to our lining. So NSAID gastritis, right? So this is what you're going to see quite a bit. So have you guys had this in pharmacy yet? COX 1, COX 2? No? Okay. So with NSAIDs, there are certain NSAIDs like ibuprofen, naproxen, very, very common. Aspirin's another one, that can inhibit the COX pathway, right? When we think about the COX pathway, those enzymes, there's actually two. There's COX-1 and COX-2. When we give these what are called non-selective inhibitors, like these ones that can affect both COX-1 and COX-2, this is going to increase that risk of that patient having this NSAID gastritis because we're taking out both of them. The COX-1 is very important in making the prostaglandins that help protect our stomach, making the mucus, making the bicarb. The COX-2, that's the one that we really associate with pain and inflammation. Okay? So there's different systems. They both make prostaglandins, we can break them out. And if you think about COX-1, you think about stomach protection versus COX-2, pain and inflammation. So when we give NSAIDs, we're reducing the prostaglandin synthesis, which is going to cause those issues I talked about. Your patient's going to have dyspepsia. Dyspepsia is a generic term where somebody's stomach doesn't feel good. They have heartburn, they have bloating, they have nausea, right? It's non-specific. That just means their stomach does not feel good. In severe cases, if they have chronic inflammation, they can actually have those ulcers develop, which can cause bad emesis. They can actually vomit blood. They may have bleeding, so whenever they swallow that blood, it's going to be melena. It's going to be dark black looking stools. If they're bleeding for a long time and we're not catching it, like I told you about my patient who had that a while back when he told me he had palpitations, I didn't believe him, and then turns out he had this and had an ulcer. So they can have iron deficiency anemia because we're bleeding out slowly, and then like I said, perforation. Now, to treat this, we have to stop what's causing this. That's the number one thing you have to do. You have to stop the offending agent. If somebody has this, and you just give them a medication like a proton pump inhibitor, and you don't stop what's causing this, the NSAID, whether it's aspirin, whether it's ibuprofen, whether it's naproxen, if you don't stop it, you're not going to get better. It may help if you give them a proton pump inhibitor, it may help. But if you don't stop the anti-inflammatory, they're not going to get all the way better. And once you stop whatever medication you gave them to treat, it's going to come right back. So they have to stop this. If you have to give somebody an NSAID, there are COX-2 inhibitors. They only act on COX-2. So it protects that COX-1 pathway, which makes the prostaglandins, which protect our stomach. If you have to, you can give them a COX-2. In reality, I don't give them any. I take them off that if I can. But some patients have a lot of pain, and so they may need it, but you warn them about the risk. But if you really, really need to, you can give them a COX-2. That's going to help cause them to make the COX-1 prostaglandins, which are going to be protected, and stop that pain inflammation pathway. Make sense? And here's what that can look like on a EGD. When you look at the stomach, you kind of see this inflammation, this irritation. You get these erosions. Again, you got to stop that offending agent. All right, autoimmune gastritis. So with this one, we have antibodies that attack the cells that make the acid in our stomach, the parietal cells. The parietal cells, though, they do two things. They make hydrochloric acid, but they also make something called intrinsic factor. Intrinsic factor is very, very important to absorb B12. If we don't have intrinsic factor, our body can't absorb B12. So when we have an autoimmune disease that attacks the parietal cells that make the intrinsic factor, we don't make it anymore. And as a result, we can't absorb B12. Now, with B12 deficiency, we kind of talked about it last block, right? You're going to get that macrocytic anemia. You're going to have those big RBCs. You're going to have those hypersegmented neutrophils. But the problem with that is that our liver can store B12 for a very long time before we actually run out of it. Most of the time when somebody actually has this, they're not going to present with stomach pain or stomach issues. It may be vague, but most of the time they're going to come with, since they're neuro deficits. For example, they're going to have like clumsiness, they're going to have maybe some numbness, tingling, because B12 is very, very important in making myelin for our nerve cells. And we don't have that, our nerve cells are not going to function like they're supposed to, so our patients are going to have these kind of weird neural symptoms. That's typically what patients come and present with. They don't typically come in for stomach issues. They come in and say they got these, and this pattern is not going to make sense. It's not going to be like it's not gonna be, I know you guys haven't had, neurology yet, but, typically if a nerve is impacted or impinged, it has this pattern, right? These patients are gonna have these kind of weird nerve symptoms that don't make sense. As time progresses, they're gonna have anemia because we're not making our red cells like we're supposed to, so our body's taking them out, so we're gonna have that macrocytic anemia. The way we treat this, and the way you identify this is you obviously get a B12, you can order a lab and get a B12 on a patient. There are actually antibodies that you can check for. They're called intrinsic factor antibodies that if they're elevated, that kind of points you in that direction. The way we treat this is that we give B12 injections. So we give B12 injections, IM injections. We don't give them pills. If we gave them pills, what would happen? It's not going to work because they don't have intrinsic factor. So we want to give it to them in their muscles. That way their blood can absorb it. Does that make sense? If you give them a pill and they don't have intrinsic factor, it's not going to work. Yeah, typically this is one of those things that we're working up, and we may see that macrocytic anemia, but most of the time the patient's going to come in with non-specific neural symptoms. All right, H. pylori. H. pylori is out there. A lot of people have this as well. It says 30 to 40% of the U.S. population. I think it's like probably higher than that now. Most of the time when these people come in and have H. pylori, they're going to have these very, very symptoms similar to GERD. With H. pylori, it's a bacteria that kind of lives in our stomach, right? And we get this typically through fecal-oral route, meaning somebody had it, they didn't wash their hands correctly, they made your food, and then you got it. You can also get it through oral secretion, so they have found H. pylori in like plaque, in dental plaque, and then gastro-oral, so you're taking care of a sick kid, they vomit, you get their vomit, and they have H. pylori, you get their vomit on your hands, and then you don't wash your hands, and you touch your mouth, you can get it as well. So it's very, very common. The problem with H. pylori is that it's going to present like somebody has GERD, right? They're going to have this heartburn, they're going to have this inflammation in their stomach, they're going to have dyspepsia. They're going to come into your clinic, and you're going to try to treat them like they have that. You're going to give them medications to treat their heartburn, and it may help, but as soon as you stop that medication, it's going to come back. These symptoms are going to come back. If somebody has H. pylori, it's not the acid that's causing the issue, it's the actual bacteria that's causing inflammation in the stomach that's causing this issue. So if we don't take care of that bacteria, if we don't get rid of it, then we're not going to get our patient better. There's different ways to test for this. Probably the easiest way, I think, is this H. pylori antigen test. It's a stool test where a patient goes off to the lab, they send a sample, they collect the sample, and then if they find the antigen in that stool, if they have H. pylori, then we treat that. The thing with H. pylori is that, or with this stool test, is that you have to hold, most of the time these people are on medications like omeprazole, those PPIs. Most of the time you have to hold that PPI for 2 weeks before you test for it. If you don't test for it, when that patient goes and submits that stool sample, it could be a false negative, meaning that they have H. pylori, but because you didn't withhold that PPI, we didn't catch it in time. Because H. pylori, it likes our stomach acid, and whenever we try to decrease our stomach acid, it actually go into the mucosa of our stomach. As a result, when we give a sample, it's not freely floating, and so when we go and submit that sample, we're not going to catch that thing. Urea breath test, that's another very good test. It's very hard to get actually out there, especially depending on where you work. But essentially, a patient takes, you give a patient urea to drink. H. pylori has this enzyme called urease that breaks down urea in our stomach and it converts it to ammonia and CO2. And then that mixture that we give them actually has this tag CO2 that when a patient drinks it and then they have H. pylori, we have that patient exhale and we're actually able to see the kind of tag CO2. So it's a very good test, it's very sensitive, but it's very hard to get out there. The antibody test, I don't know why they have the antibody test. If you're ever out in clinic, don't order it. I don't know why they have it. It doesn't tell you if they have an infection. It may tell you that they had a past infection, but what you care about is do they have an infection now? If you do an antibody test, it doesn't tell you anything. Don't get it. It's not worth it. And then endoscopy, that's probably the for sure way to see if somebody has H. pylori. What they'll do is they'll go in, take a sample of the gastric mucosa and then send it off to lab and see if they have it. But the easiest way is that fecal H. pylori antigen test. That's the number one way. We treat this. There's different ways of treating this. Typically, it's called triple therapy. We'll give a PPI, we'll give a couple antibiotics, and then hope that they're good to go. There's a lot of resistance to this though, antibiotic resistance, so it may not work. But that's why you have to make sure that you have to do a test of purity. You have to make sure that whatever you gave them actually eradicated that H. pylori. If you didn't, you don't know whether or not it worked. You have to make sure that the antibiotics actually kill the bacteria. Because if they don't, and because like I said, the H. pylori is very resistant to this triple therapy. That chronic inflammation can increase their risk of developing gastric cancer. So, you got to make sure that you get that tested through. All right, peptic ulcer disease. This is what you worry about when you have H. pylori, or when you take inserts for too long, or if you smoke or drink too long. That chronic inflammation can cause ulcers in our gastric mucosa or in duodenum. With these, it's kind of hard to determine whether or not somebody has an ulcer based off symptoms alone. If somebody has a shallow ulcer, they may have this kind of vague pain. They may have dyspepsia, this kind of non-characteristic, uncomfortable feeling in their stomach. So, when somebody comes and they have GERD, is it really, or gastritis, is it really just gastritis, or is it an ulcer? You don't really know, right? If it's a deep ulcer, though, potentially that can erode into a blood vessel, and they can have hematemesis, or they may have black liquor still from that melena. If it's a very deep ulcer, it can actually cause perforation. And when you get air into your abdomen, whenever you perforate that stomach, and that air goes into the abdomen, your patient's going to know it, and they're going to tell you. They're going to have this severe, intense abdominal pain. Also, on top of that, whenever you leak out the contents, you're going to create that peritonitis, right? You're going to cause an inflammation in the peritoneum, and it's going to cause the patient to become very, very sick. You can shoot an upright abdominal x-ray, and sometimes you can see that area in the abdomen. It's called pneumoperitoneum. But it's very, very hard to differentiate between shallow ulcers and gastritis. But the deep ones, if there's blood involved, then that tells you something, right? Perforation, you'll definitely know that. For the shallow ulcers, we'll typically treat that with those PPIs if we know it's that, right? If there's H. pylori involved, then we're going to treat them with that triple therapy. If it's a deep ulcer and there's bleeding or perforation, so if somebody comes in and they have symptoms of GERD or gastritis, they have dyspepsia, and they tell you that they're vomiting blood, they need to go see a surgeon, right? You don't need to, maybe you'll start them on something, but you need to get them to a surgeon right away, because then they need to go in there and kind of see how severe it is. If it's a perforation, well, I think that makes sense. If somebody has a perforated stomach, you need to get them to a surgeon right away. There's an example of kind of what that could look like. So shallow ulcers, no pain, no bleeding, but they may have pain. The deep ulcers, that deep ulcer part, you can see there that they may have bleeding or they may not. If there's no blood vessel in the pathway of that ulcer, they may not have bleeding. So that's why it's kind of hard to tell in real life. But if there is bleeding, if they're vomiting blood or they're having that melena, then that's a sign that you need to get them to a surgeon. And perforation, I think we know that already. That can lead to peritonitis, so they need to go see a surgeon right now. So here's an example of kind of what the shallow, deep, and perforations look like. That shallow is just that submucosa, so it looks white under that. Looks white versus that deep one. That black part that you see, that's from bleeding, and as that blood becomes oxidized, it turns black. And the perforation, you can see that hole kind of right going straight through that. So here's what that free area in the abdomen looks like. Again, this is normal, right? This is where your stomach is, but then right here, you should not have the space here. You have air in that space, that tells you that there's free air in the abdomen, and that typically means that there's a perforation. That's it. Questions? All right, go ahead.
Sorry, sir, I missed it. How do you differentiate between shallow
It's hard. It's very, very difficult. It's very difficult. So the way you tell in real life is that you send them to a gastroenterologist, they do an EKG, and they look for that. Yeah. In here, I'll make it known. It's gonna be clear. I won't do that to you.